Hello, everyone. Welcome to Ritco Physiotherapy's aged care training presentation. This presentation will talk you through all of the important and fundamental aspects of aged care. In particular, it will educate you, for those of you who haven't worked in aged care before, on the aged care funding instrument, which is the primary government funding system for ensuring that residents in aged care are well provided for. It is this very funding instrument under which allied health professionals work. And the purpose of this presentation is to not only educate you and make you comfortable about working under this aged care funding instrument, but also to highlight how important it is for us as allied health professionals to stay true to the directives of this funding instrument. So, the aged care funding instrument is also very commonly referred to as the ACFI, which is just the short form. And you will see this word being used quite often by clinical managers and facility managers on site. So, the sooner you get familiar with this word, the better. Now, I've given you a hard copy of the ACFI instrument. If you haven't received one, please let me know. But on the hard copy, you will see that as the primary funding tool for residents and aged care, it's divided into 12 separate sections or domains. And there's different domains that basically fund different aspects of care. So there's a separate domain for behaviors, a separate domain for complex healthcare, and so on and so forth. Now, the good news is that we don't actually have much to do with 11 of those domains. We, as allied health professionals, fundamentally provide services under domain 12, which is the complex healthcare domain. This domain is further divided into separate directives, okay? And I know it's a bit confusing, but what you need to remember is that as allied health professionals, we're only concerned with domain number 12, which is complex healthcare, and with only three categories or directives under that domain, which is Directive 4A, Directive 4B, and Directive 3. Now, when the ACFI first started, allied health professionals were used by facilities to provide services under 4A, 4B, and the 3 claim. But as the aged care funding instrument has molded over time, and it's been changed and reviewed several times, and that might happen again. There's no guarantee. What has happened is that allied health professionals now, in this day and age, generally are only used to provide services under the directive of 4B. And certainly at most of our facilities, that is the directive under which you will be providing services. So that should make you feel a bit better, because even though the ACFI is one very, very complex, complicated funding instrument, you don't really have to worry much about it, apart from knowing that you come under Section 12, 4B. Okay? And the 4B has a very distinct directive. It very distinctly states that pain management services must be provided by an allied health professional over 4 days, totaling 80 minutes of treatment time for the week. So I really want to emphasize here the 4 days over 4 times. So you can't actually provide 2 treatments in one day and then another 2 treatments on another day and count that as 4 treatments, because the treatments have to be over 4 separate days. So that's really important for you to understand, that our treatments are provided over 4 separate days. Now, because over those 4 separate days, at the end of the week, it has to total to 80 minutes. Generally, we divide those 4 sessions into 20-minute sessions each. So, for example, if you have a resident who is on a 4B claim, as you will have quite a few, because that's fundamentally a lot of what you'll be doing, it is your obligation to see that resident for 20-minute sessions, therapy sessions, 4 days a week. Anything lesser than that, and the terms of that directive would not be met, in which case the facility could be downgraded or could lose funding because of your non-compliance with that directive. And this is very important for you to understand, because I will often get after you to ensure that you have provided those 4 treatments and have, more importantly, documented those 4 treatments. And I will teach you how to document them throughout this presentation, and also in person when you have your training. But it's very important for you to understand that those 20-minute sessions have to be provided to each of your residents on a 4B claim over 4 days. Now, I guess all of you are wondering, how do you know when to add someone on a 4B pain directive? It's actually pretty simple. All you need to do is a pain assessment, which all of you will be doing anyway every time there's a new resident, because you have to complete a comprehensive physiotherapy assessment on them. And as part of that physiotherapy assessment, you assess many things. You assess their mobility and transfers, you assess their coordination, their range of motion, their strength, and you also assess their pain. During the pain assessment, you will need to do a pretty thorough assessment. It's not enough for you to just state the area of pain. You need to actually provide the government and the aged care funding instrument with justification as to why you are claiming funding for 4B. Therefore, that justification will be sought in your pain assessment. So in your pain assessment, you need to document obviously the area of pain, and there can be more than one area of pain. There's no limit to how many areas of pain a person may have. Generally, you'll find, as a rule of thumb, most people will have pain in 2 or 3 areas. The common areas in aged care where you'll find pain is lower back, shoulders, and knees, mostly due to degenerative changes in their joints because of aging. A lot of times they also have the aging and degeneration on top of a very distinct diagnosis of OA, and that can cause pain as well. So the pain assessment must record the area or areas of pain. It must record the nature of pain. And under the nature of pain, we're basically looking for descriptors about what sort of pain is it. Is it constant? Is it intermittent? Is it sharp and stabbing, or dull and aching, or a combination of the two? Some people have dull and aching pain at rest, but then on certain movements, the pain becomes sharp and stabbing. Are there any aggravating factors to the pain? For example, if Mr. B has a right shoulder pain, what aggravates the right shoulder pain? Is it overhead activities? Is it more aggravated when he's dressing, when he's walking with a walker, and from holding onto the walker and putting pressure on the walker? Those sorts of things would go under your aggravating factors. I also would like you to get into the habit of documenting somewhere on the pain assessment whether the resident is describing any neural symptoms. So neural symptoms can be symptoms like pins and needles and numbness. And often you will find residents who have a history of sciatica or disc bulges, or nerve impingement in the cervical area will often show those pins and needles and numbness sorts of signs as well. And that is an important aspect for you to document. And finally, it's also important for you to document a severity rating. So how severe is the pain? Are we talking about mild pain, moderate pain, or severe pain? Now, obviously, because this is a funding instrument and you're claiming 4B, which is quite a significant chunk of funding that goes towards the 4B claim, the government wants to know if you're claiming that amount of money for mild pain. So if it's really mild and there's not enough of a justification for providing treatment 4 days a week, they're likely not going to fund it. And therefore, your pain rating on the VAS is really, really important, okay? The VAS being the verbal analog scale. So basically, you would ask the resident to rate how bad their pain is on a scale of 0 to 10, 0 being no pain and 10 being the worst, most excruciating pain they have ever felt. Now, if your resident is recording a pain level of 2 on 10, that might not be a pain level which may get funded. So when you do your pain assessment, you need to provide a VAS score that is appropriate to the level of pain your resident is displaying. Okay. Now, some residents are nonverbal, particularly residents who are in dementia wards and are suffering with dementia. They will tend to be nonverbal. And if they're nonverbal, that doesn't mean that you can't do a pain assessment. It just means that you need to do a nonverbal pain assessment. So you can refer to the Abbey Pain Scale. The Abbey Pain Scale is very readily available on the internet. If you've never used the Abbey Pain Scale and you don't know what it means and how to interpret it, please ask me and I can provide you with some information. But essentially, what the Abbey Pain Scale does is that it looks for pain through nonverbal signs. So if they're unable to verbalize pain, as some people with dementia are unable to, then you would look for pain through nonverbal signs such as resistive behaviors, facial grimacing, agitation, vocalizations, and so on and so forth. And if you are finding that, when you palpate someone's knee firmly, they are pulling away or resisting, or they're getting agitated, and there's a sudden change in behavior because of your pain provocation, then that is seen as a pain symptom, and that can be documented, and you can claim funding for that based on the nonverbal signs that you have seen. And often we will use those nonverbal signs of pain, not just for residents who are nonverbal, but also sometimes you will need to use them for residents who have a cognitive deficit. So sometimes they are verbal and they can verbally tell you whether they have pain or not, but because they have cognitive decline, they might not be able to express themselves properly. They might have expressive dysphasia, and so you can resort back to those nonverbal pain scales again. So if a resident is found to have pain issues through your assessment, we can then add them onto your 4B pain list. Now, details of how to add residents on your 4B pain list and how to chart them and how to record each treatment after you've provided it, that is those 20-minute sessions over 4 days, all that will be discussed at your training and orientation when you sit down and sit across from the eCase software, and I'll take you through that step by step.